different height, length. They have short implants and they have long implants, and they have narrow implants and wide implants, a wide range of implants. After dinner, if you can pass by the booth outside, you can see and feel the implants, and you can see the surgical kits. They are representing that outside. Concern the aesthetic, we have, they have the zirconia abutments that will give you more pleasant and excellent aesthetic results and results. So they have that one. I think this is one of the good point of, to mention over here. The height can be maintained over abutments. Whenever you have let's say that you place your implants, you have certain height of soft tissue, and you want to maintain that. So they can help you maintaining the same height of soft tissue by selecting the proper healing abutment, final abutment, and later on, if you want to go for different choices, up to the locators, the attachments for removable dentures, they have the same height, will help you to maintain, standardize your soft tissue height and maintain it over the implants. Also, they have a variety of choices. If the restorative dentist wants use different height, different diameters, different emergence type, or even the angulation, they have a good variety of choices to properly select the size that you want to use. So they can help you to select your proper size and then restore the implant later on. They have also the temporary, whoever is concerned about the temporary abutments, they have temporary abutments that help you to restore the implants temporarily. Thank you so much.
Can I ask Jill to come to the stage? And Dr. Uthman, please remain also. Jill, can you please come in? We'll open now the floor for discussions. For any questions, who wants to start? Please.
Thank you so much. Thank you so much indeed. Who wanted to ask about the minimal invasive choice when you have vertical resorption of the ridge, or vertical bone resorption. When you have vertical bone resorption.
Yeah, very good question.
Yes.
Actually, I don't know if we will have time to, because I was supposed to present you all my clinical cases in the second part, but I think that we are short of time. It's a pity because it will show you, well actually maybe you will invite me a second time, but all these cases, and I've cone beam, and we'll show you that I'm not using any biomaterial at all. And will be the translation exactly of what I was talking in the first part. Anyway, this is a good question because we have limitation. We have limitation. The first limitation, I will say, will be the loss of the buccal plate. We all know that if you have the loss of the buccal plate, in any cases, you will need to graft. Well, my option will be in grafting a bone J graft block, autogenous graft. In case of vertical resorption, of course, here there's a problem. Because either you're working in minimally invasive surgery, if you don't have the bone, there's no way of managing these bone volume. In these cases, I will try to find any alternative solution. Like, for example, what do you mean extraction?
Distraction.
Oh, distraction. We all know that distraction has been invented for publication sakes, you know, because it's nice to publish on destruction. Who's making destruction? Well, for a publication, that's all. We have to face that very often. I'm giving this example about aesthetic. You probably go to different conferences about implants, implantology. And have you seen how many cases are presented about aesthetic in the premaxillary? And who here in this audience has, I don't know if you have a lot here, but usually I'm taking this example. How many of you have top model, 25 years top model, 1 meter and 80, that present Monday morning in your office with a broken front tooth? That means that, of course, aesthetic is an issue, but do we really have all these aesthetic cases? Not really. I'll tell you what, in my own office, it will represent less than 4% of my cases, of my implant cases. So that means that in these cases, I will try to find any alternative issues. That means, for example, if I'm working on Holland 6, I will tilt it my post implants. For the same reason, I will do the same in the mandible, in the lower arch. If the atrophy is medium, and that I know that because of gaining on this primary stability, that I can use a low profile implant, not a mini implant, but a short implant, then I will use my short implant in maybe raising the diameter of this implant. But in doing this, we all know that the rate between the prostate and the implant is very important. And usually we know that we don't want to go up than 50%. But in some cases, because you are gaining in this bone density, so maybe you can, and actually I had some cases about this, but this is an option. But honestly, I will tell you, and we have a lot of cases that were promoted by, for example, Testori or other groups, Simeon in Italy, and showing vertical bone regrowth. That's not possible. It makes, again, it makes a nice publication. But here is a real BS. Because in the long term, we know that it will collapse. Most part of them. Except if you are a magician. But I'm not.
Any other questions? Yes, please. Dr. Ibrahim.
Same like these cases, do you prefer to use tension-supported implant instead of fixed implant, or with the horizontal bone or vertical bone?
Which kind of implant?
Tension-supported implant.
Overdenture. Yeah, again, I had some cases. Again, depends on the request of your patient. Of course, this is my first issue. Second, implants supporting overdenture is a good solution. And I tell you what, I mean, in some of those cases, and because in France, in south of France, we have a lot of people, old people, that are retiring. And these people, they just want to